Welcome to On Becoming a Healer. This is Saul Wiener. My co-host Stefan Kertez is not able to join us today. My guest, Martin Shapiro, has recently published a book called The Present Illness: American Healthcare and Its Afflictions. And this long book takes on a major topic, which is where we are as a healthcare system today. And then sort of embedded in that is a conversation about the doctor-patient relationship. When I read the book, I sort of sensed a paradox. And for me, the paradox is that on the one hand, the ideal physician is caring, emotionally trustworthy, capable of meeting patients where they are. And on the other hand, the profession is suffused with money, power, status. These things don't mix well. And yet the profession wants to have it both ways. Dr. Shapiro takes this on across the spectrum of the development of the physician and the profession. And actually, early in the book, there's a conversation about the white coat ceremony. And as many of you know, this is a solemn ritual filled with pomp, circumstance. It's held at nearly every medical school. It's generally a revered ceremony with proud parents, senior faculty, deans, speaking of high ideals, praising the incoming students for their accomplishments. And of course, they don these white coats. And it's generally a kind of welcoming into the profession, into the guild. And Dr. Shapiro writes, quote, "The foundation that promotes the ceremony states that, quote, the iconic ritual provides an important emphasis on compassionate, collaborative, scientifically excellent care from the very first day of training. This formal agenda," he writes, "is admirable, but it belies the atmospherics and hidden curriculum of the event. It is primarily an act of socialization." He goes on to observe that, quote, "As they don their white coats, entering medical students are separating themselves from other elements of society. The white coat is frequently associated with the medical profession. Its whiteness can be a symbol of purity as well as cleanliness, but it is also a cultural symbol of power and authority. Many of these newly minted medical students," he goes on to write, "have accomplished little other than good GPAs and test scores, but the inherent message is that they have arrived. Why socialize them with a status that effectively communicates that they are part of the elite? I would argue that doctors should not have such status at all," he says. "At the very least, shouldn't they have to earn it by first appropriating their medical skills for the greater good?" Now, I recognize that people will push back at what Dr. Shapiro was saying. After all, the white coat ceremony is revered. Isn't it good that we give students a sense of sacred responsibility as they enter the guild? But I think Dr. Shapiro is onto something. In preparing for this episode, I watched a lot of white coat ceremonies on YouTube. And while they differ quite a bit, one thing that I noticed is what is absent, what is missing from these ceremonies. I noticed that they don't caution against the way in which money, power, and status so often corrupt the lofty ideals espoused at these ceremonies. Now, one might say, it's not the time to do that, but is it not? Another thing they don't do, which is a central topic of Dr. Shapiro's writing, is talk about the incredible personal growth that is necessary to connect with a sense of shared humanity with people who are suffering, frightened, and in pain. Medical students arrive with high MCAT scores and GPAs, but they are rarely, if ever, prepared or ready to form those connections. And honestly, probably few ever do. So I've invited Dr. Shapiro on today because I see him as a sort of truth teller. His book is quite scathing about the profession, with thousands of footnotes to back up what he has to say. And at the same time, it is filled with many stories of patients he and some of his colleagues have cared for with love, concern, and connection. But doing so has required confronting and rejecting much of the mythology about the profession. So I think if there's one message in his book that stood out for me, it is this paradox that in order for us to find a way to truly connect with patients, to grow, we have to be honest and candid about the system we're in, about the way in which it can change and corrupt us, and also about the ways in which our education and the way we are selected as we come into the profession is flawed. So before we have this conversation, I'd like to introduce Dr. Shapiro and tell you a little bit about him. He has quite a remarkable background. He's a physician who also has a PhD in history and an MPH. He's a professor of medicine at Weill Cornell Medical College and previously spent many years at UCLA, where he was distinguished professor of medicine and public health and chief of the Division of General Internal Medicine and Health Services Research. He's practiced both primary care and inpatient medicine, and his scholarship is vast, spanning HIV care, health disparities, scientific misconduct, and pharmaceutical advertising. He's trained and mentored countless physicians, and he served as president of the Society of General Internal Medicine, to which I am a member. But what makes him special, in my mind, is that he has never bought into the system. And I mean that literally. This is a guy who actually declines pay raises. So, welcome, Dr. Shapiro. May I call you Martin?
Absolutely.
Great. Thank you. So, I'd like to start with a broad question. What are some of the ways in which medical students, trainees, and physicians in practice are shaped by money, prestige, and power that could potentially undermine patient care?
Well, of course, they're affected by the environment in which they have grown up. And we certainly live in a society, and today, of course, people talk about a new Gilded Age where money and more money is the ideal. When they enter college, there are many students there who are concerned about their occupational status, their capacity for earning a living. Many of them drift towards pre-med curricula, and it's not just, I believe, because of an interest in the sciences or in helping humanity, but because it's a profession that offers a lot of security and a very good income. The selection process for medical school favors people who do extremely well on their courses and on their tests. And there is no real stimulus to efforts to broaden one's perspective, to immerse yourself in the community, to dedicate yourself to the well-being of the population. I stumbled into medical school. I wasn't sure what I wanted to do. I thought about doing a lot of other things. And when I made that decision, I had a conversation with my uncle, who was a progressive man, lived in Montreal. And he said, well, it's good that you chose medicine. If most of the other careers that you'd considered, you pretty much have to take the jobs that were available. In medicine, you will have choices. You can choose to figure out how to make as much money as possible, or you can choose to serve humanity. And on the basis of the choice that you make, we can judge your worth as a human being. Well, of course, that was a very intense thing to hear as a 21-year-old kid, but it was a gift, and it's a gift that continues to help me, because there isn't a week that goes by that I don't think about that conversation and ask if I am doing enough, ask what is my worth as a human being? Have I lived up to the potential? And of course, the answer is, well, as long as I have breath, there's still more opportunities to do more good. You spoke of the white coat ceremony that I had commented on, and I do think of it as very much an exercise in triumphalism for these students. It's worthwhile thinking of some alternate things that people might do at the moment that they enter a new occupation. Think of Pope Francis. On his first day on the job, he washed the feet of poor people. And along the way in medical school, I don't think students get very many opportunities to get the kind of gift that my uncle gave me, to be challenged, to live up to one's responsibilities, to face the reality that they're making moral choices all along the way. I work with the medical students at Cornell. They all have to do a research project, and I help them, along with some other faculty, and identifying mentors to work with on these projects. But it's very interesting because on day one, a large proportion of the class already know that they want to go into the highest paying specialty.
Yeah, I was thinking of a story in your book about this talented student on the M3 internal medicine clerkship who you were the attending for. And, he's quite sensitive to patients. He seemed to really enjoy what he was doing. He seemed like a perfect fit for internal medicine. And when you shared that with him, what he said, and I'm actually going to quote from your book, he said, quote, he had taught, well, first I should actually say, he mentioned that he had talked to some of his fellow students and that they had discouraged him from going into internal medicine because it said, quote, your test scores and grades are too good. It would be a waste. And then you go on, you write that it is unfortunate that money, and I would add status, drives such decision-making. While every specialty is a legitimate choice, awareness of what it means financially is, in a sense, a corrupting influence about the career decisions of medical students.
Yes, I do feel that. And I think it's a shame, but there is so much temptation. And I think part of it reflects the pressures within medical school, certainly the ethos in the class. Some of it reflects the values that they came in there with. I think we could do a much better job of selecting medical students. When I was applying to med school, I asked one of my professors for a letter, and he said, sure, happy to do that. Anyone can be a doctor, which I thought he was jesting, but you don't have to have exquisite and exhaustive scientific knowledge to be a doctor. The most important tenet of a doctor is a moral posture that embraces the need to connect humanly with patients and a willingness to forego potential for hiring in order to do the right thing for every patient every time.
Reflecting on what you just said about how much science you know, and I know I would not pass any of the classes that I took as an M1 or as a pre-med at this point. If I was given a biochemistry test or an organic chemistry test, any of those tests, I would hopelessly fail. I think that's probably true of the vast majority of physicians. And so we were forced to learn a lot and memorize a lot and regurgitate a lot, but we don't use it. And of course, much of this we could go look up if we needed to. So I think it is important to reflect on that, because one then has to ask why in the world were we asked to go through and jump through all those hoops in the first place? And I'm curious about how you would answer that.
Lewis Thomas, a distinguished scientist, former dean of one of the leading medical schools, wrote years ago that we should get rid of all the science requirements in medicine. And he said replace it with classical Greek, but I assume that was somewhat metaphorical. What he meant, an education in the humanities is vital. And I certainly think that that's the case.
And then in medical school, of course, we would have to design. Obviously, there is science. There's a science and a scientific foundation. But I think what you're getting at is it's far less and far more specific than what is currently required. Is that where you're going with this?
Yes, of course. You want people to understand about which hormones are generated by the pancreas and what you have to do about glucose levels and things like that. But a lot of the science that you learn in the pre-med course is not relevant. Yeah, I mean, I took one biology course. The only thing I really remember from that course was the central dogma of cell biology, which was that RNA can never go to DNA, which of course was wrong. So, but somehow I got past that and was able to function as a professor in a medical school.
It's interesting because I think this discussion, a lot of people will rebel against this discussion because it's so deeply embedded that this is part of our identity, that we know all this, we quote know all this stuff. Of course, we don't remember it. But I think the ugly side of medicine, which is the emphasis on status and money, is prevailing theme in your book. And it's not just the medical student who says, I'm too smart and too good to do what I love, which is internal medicine, so I'm going to do something that pays better. But I remember you also describe a colleague of yours, and you were kind of surprised by this when he said that he was an internist, actually, which is interesting. And he basically said that he had to order PFTs a lot on patients when he knew it wasn't indicated. He wrote that he sometimes felt bad about ordering pulmonary function testing when he knew it wasn't necessary. But, quote, as he said, I need to pay the rent.
Yeah, the economic environment is always there. And unfortunately, of course, there is so much financial incentive to order procedures. Now, the pulmonary function test that my friend, the generalist, was ordering, that's small potatoes relative to the endoscopies, the catheterizations, the surgical procedures that people may or may not need. But there's a tremendous incentive to get those. And subspecialists are hired by institutions with the expectation that they're going to produce a certain number of these procedures. So there's pressure on people, not that they're resisting the pressure, mind you, but there's pressure on people to do that. And of course, the expectations of the young physicians when they come out, that they can't imagine living on $220,000 or whatever it is a year that a general internist on average earns, maybe a little bit more now, which is several times what people who are just as hard and are just as good people, just as deserving of a decent life earn as they work very hard, sometimes harder than the doctors.
Yeah, you write that, and you look at this from a historical perspective, that back in the 1940s, the differences in pay among specialists and generalists were comparatively slight compared to what they are now. And you cite relatively recent data from a national survey showing, and I think most people know this, the vast range. And so if you're looking, and it's interesting how the brain works, 220,000 or 230,000 starts to look paltry when you're like, oh, I could be making 600,000 or 700,000 if I choose this specialty instead. And so I think, unfortunately, that becomes a corrupting influence that has emerged over the decades.
So how do we counter that? Well, we need to do a much better job of identifying people who are at least somewhat resistant to that, who have more intrinsic altruism. And there are ways of measuring this. And of course, people can be deceitful. Students put all kinds of serve humanity stuff into their applications. But there are ways of measuring it, perhaps on the basis of what people have done in their lives, how they've spent their time. There's also the problem of being able to connect with patients and whether that would be a priority. And of course, connecting with a patient takes time, sitting with them, talking to them, relating to them. And people very often who do procedures don't want to spend time doing that because it's time away from generating the revenue that they want to generate.
Yeah, I'm thinking about one of the stories that you tell about a man in his late 20s, a 28-year-old who had been diagnosed with stage 4 Hodgkin's disease. And what stood out was that this young man's brother had died recently. And so the patient was skeptical about the healthcare system and initially didn't want to be treated for this incredibly treatable disease, which of course would have been a death sentence for him. So you spent a great deal of time essentially trying to provide him with evidence. He was quite well educated, and you actually even took him down to the path lab so he could see his own slides. You called him several times to make sure that he didn't bail as he approached treatment and so forth. And it paid off. He eventually was cured. And what was striking is you couldn't bill for most of this work. I want to quote what you wrote here. You said, quote, "I did not consider myself to have been underpaid for what I did. I know that my interventions saved his life. The diagnosis was the easy part. Being there for him, understanding his anguish and doubt, supporting him until he had enough treatment to maximize his chances of cure, all were essential. I felt gratified about what I had done. The system of reimbursement rewards the specialist substantially for what he or she does. I likely was paid 1/10 or even less of what the cancer doctors in their departments received." And then you also wrote, "This man was terrified. He needed hope and comfort, but he also needed evidence shared with him in a way that he could fully grasp, that he would not die as his brother had recently. He also needed a physician who was willing to spend the time needed to accomplish that."
Yes. Even now, I feel so gratified that I was able to help that man on his journey. It brings a tear to my eye now, just even thinking about that. And these are some of the most glorious things that a physician can do. And I think students often are unaware of that, the emotional benefit to the patient and to the physician of those kinds of connections.
Another example that stood out for me was Richard, who was 37 years old. And this was a much more unfortunate situation in that you were his doctor and you picked up on a mass, and it turned out, and during a routine exam, and it turned out that he had a duodenal malignancy that ultimately turned out to be resistant to treatment. And he became very ill. His suffering was protracted. He was miserable. But during that journey, there were many points at which you were able to intercede. Early on, before it was clear what his diagnosis was and he was still feeling well, you were able to encourage him to just go home and spend Thanksgiving with his family. And then later on, as he was suffering and it was looking increasingly bleak, you essentially gave him permission to stop his cancer treatment and to give his family peace. And then after he died, his mother reached out to you sometime later to say how helpful that you had been on that journey with them. And again, I want to read here something you wrote. You said, quote, "I earned far less than the surgeon who operated on him, the oncologist who gave him chemotherapy, or even the anesthesiologist who spent perhaps 2 hours with him in the operating room. Yet I felt amply recompensed for what I did. Getting Richard diagnosed rapidly, letting him spend a final Thanksgiving with his family before his cancer treatment, and helping him make the decision that he needed to make at the end gave me a sense of doing my job. He knew that I cared for him and he trusted me." And then you conclude, "The physician can always be a heart in a world that has dealt a bad hand to their patient. This is an imperative, whatever the reimbursement mechanism."
It is an imperative, and that is lost on many people in medicine. It is very meaningful to be able to help a human being experience their difficult moments in life in a positive way. Unfortunately, for many, the most compelling thing in the practice of medicine is the number of RVUs or procedures that they accumulate over the course of a day or a week or a year. That's not medicine as I think it ought to be pursued. And of course, we need people to be able to do these, but there should be no greater reward for doing a procedure than for caring for a patient.
One of the stories that stood out for me had to do with a patient who was very challenging at the end of life. And it reminded me of, I teach a class called Reflective Practice with third-year residents. And one of the exercises I do is I ask them to talk about a patient they look forward to seeing when they see them on their roster, and also a patient who they're like, oh God, not him again or not her again. And what I found is that in general, they like patients who like them, and they don't like patients who don't like them. If a patient provides positive reinforcement, they feel good about it. And if the patient is always complaining, and then they don't like them. And yet, one of the problems with that, of course, is that being sick does not make people at their best. And so presents a huge issue for the care of patients who are suffering. And you describe a woman who you call Tanya, who is a woman in her 50s. She was a retired ballet dancer, and you had a long-standing relationship with her. And she developed uterine cancer. It was a devastating course for her. She ended up having surgery and chemotherapy, and it began when you had noticed, again, a mass when examining her. And during the course of her therapy, you played a vital role, and your relationship with her was very positive. But at the end, as she began to recognize that her situation felt hopeless, she became very negative, and she started to lash out and to blame you. And you write that, quote, our last words were not pleasant ones, yet my recollections of Tanya are only affectionate. She needed to be angry with someone, and I was the most reasonable target. In psychological terms, transference and countertransference occur to some degree in almost every medical encounter. And then you write, Godspeed, Tanya. And I wonder if you can comment a little bit on that, because I think it's such an important example, given what I've seen in the way in which physicians think about who they like to see and who they don't like to see, and how they respond to that.
Life isn't always a positive experience, and many people have difficult paths. And doctors shouldn't expect every encounter to be a happy encounter. Not everyone is going to be grateful as they die for what you've done for them.
You talked a bit in your book about your own experience with psychotherapy and the importance that it played in your development as a physician. And I think it's an interesting issue because it gets to the question of how we don't or may need to prepare students and future physicians for these difficult relationships. And I'm wondering if you could talk a little bit about that.
Yes, I think early on, there were some patients who were really difficult patients who would never listen to my advice, who were difficult for everybody, who the clinic didn't like to have them around. I'd be exasperated when they would never follow my advice and they'd call me all the time about this or that. As I went along and through my psychoanalysis, I came to recognize that this wasn't a reflection of me. It was part of their disarray. I could feel okay about myself, even if they weren't responding to me at all in ways that I wanted them to respond to me. I think there are many aspects of being a doctor that can benefit from psychotherapy. I do tell a story in the book about the Holocaust survivor who died on a hospital ward. And I came in the next day and her name had just been removed from the list. And I knew she had died overnight and she was dying. You know, she had not resuscitate order under chart. She was a lonely woman. And I said to the house staff, why don't we talk about her a little bit on rounds? And the resident had said she coded. And of course, coded implies she didn't die. She coded. And coded implies CPR. She didn't get CPR. She didn't code. She died. So we talked a little bit about her, and we talked in her life, and we talked about our personal experiences with death. And I brought in several books of poetry, which have poems about death and dying and illness and so on. And we took turns reading them. And I read one, and I cried while I was reading. And afterwards, the resident said to me that the students had asked him if I had a cold.
Oh my gosh.
And I felt sad at that the students couldn't recognize that it's okay to feel emotion in the context of taking care of patients, because if you can't feel emotion, you often can't be the doctor that people need.
I've thought about this when I am precepting residents in the clinic. And what I've noticed, and I'm thinking of a patient recently who had come in for a routine groin sprain. And it turned out that he got this groin sprain. This is a 58-year-old man from long jumping. And I was like, what is a 58-year-old man doing long jumping? And it turned out he had been the gym coach for a local urban school and had become really obsessed with helping young kids find a way to develop confidence, to open them beyond sort of just basketball, as he put it, to other sports. And then this has become a real passion for him. And then it became clear that he was just extremely driven also to pursue athletics himself, even with injury. And there was a certain frenetic quality to him and almost desperation when he realized he wouldn't be able to do athletics until he recovered. And this led me to start to, and again, this was I should mention, this was a veteran, and I started to question him, and it became clear to me that he was suffering in some way. And so I asked him about that, and he had symptoms of post-traumatic stress disorder. It turned out that he had been posted in Okinawa in the 1980s, that there had been a tragedy there when he had arrived. It had nothing to do with combat, actually, but he was a young corporal. He had a friend with him who was also corporal, and they were having fun, I think on a day off, and they ran across the street, and the traffic was going in the wrong direction, and his friend was run over and killed. And he felt guilty because it was his idea that they dash across the street, and he had looked both ways, but his friend had not. And this had haunted him. And athletics, really intense exercise, was one of the ways in which he coped with it. And so this came out and became clear that this man was suffering. This was a major issue. And what struck me about this encounter from the standpoint of my interaction with the resident is not so much the resident missed all that, but that even when it came out, the resident didn't really seem to be moved or that interested. It was like, okay, well, I guess I should put in a consult for psychiatry. And that's happened a lot in my experience with the trainees I work with. They're technically good and they're conscientious, and they do tend to not pick up on these clues, although I do think that could come later. But it's more in my mind that even when these heart-wrenching life stories come out, that they're not moved. And it's not just that I think that doctors should be emotionally moved. I mean, patients don't benefit just because we're moved. But it's that the absence of that is a signal of some lack of shared humanity. And I had the sense reading your book that was something that you were getting at, that's somehow missing. And I'm wondering if you can reflect a little bit more on that.
I think you're absolutely right. People who are not connected to their own feelings are often threatened by having to address the feelings of others, the vulnerabilities of others. They may well have unresolved issues in their own lives. They may not even be aware that they have these unresolved issues in their lives. It was so helpful to me. And I spent a long time in psychoanalysis. I had a lot to deal with, but it certainly helped me a lot going forward. So I do think that strongly encouraging physicians to take on some of their internal stuff. Psychoanalysts all have to go through psychoanalysis. And I'm not saying that long-term psychoanalysis like I did is going to be for everybody, but some kind of insight-oriented therapy can be invaluable in terms of being able to connect to patients, feeling okay about embracing the range of emotional reactions that people present with, and helping them address their problems is very valuable.
In an earlier podcast episode, we focused on what's called medical gaslighting. There had been a series of essays in the New York Times and a Washington Post with thousands of comments from patients about negative experiences with their physicians. And it's interesting because I think most physicians, probably all physicians perhaps, think of themselves as caring and conscientious. I mean, that's the story we tell ourselves. And yet there are these blind spots. And in fact, they may be more than spots. They may be gaping holes. And what came out in the thousands of comments to these articles was that physicians often come across as rude, patronizing, even humiliating, and that this especially occurs in their interactions with certain groups like female patients and Black patients and other marginalized groups. And I think that many of these physicians, perhaps almost all of them, are unaware of the way in which they're being received. And so it seems like the phenomenon, the problem goes even deeper. And I'm curious about your thoughts on that.
Certainly, people's experience, the experience that people report, are valid observations, and so there's no doubt that physicians aren't always responding to them in a way that is optimal. Now, sometimes patients may be angry, like my patient was angry, for reasons that it's hard for the physician to address. But a lot of the time, that's not the case. I mean, I certainly had many experiences as a patient when I was treated dismissively or unkindly. And I know lots of people who've had experiences like that. I argue in the book that compassion, emotional connection, empathy, and altruism are absolutely essential components of what every physician should be. And that arguably half of the first 2 years of medical school could be devoted to trying to build, enhance, or at least retain elements of this rather than the opposite. And that would not be time wasted.
It reminds me of an incident you describe at the medical school in which the students were learning about grief. And a woman came in to talk about the grief she experienced losing her young husband to cancer and to talk to the students about it. And you wrote, quote, she talked about her pain and her anguish. A number of students got up and left the room while she was talking. Some sobbed in the hallway. Several complained that they should not have been subjected to the presentation and that they should have been allowed to skip such a session. And then you go on to write, physicians need to be able and willing to relate effectively to grieving patients and their families. If students are not willing to acquire the ability to do so, they shouldn't be in medical school. In reality, while some medical students want to be able to work effectively with patients, others have little or no interest in acquiring the skills needed to have difficult conversations or to deal with situations that are emotionally challenging to them. They prefer procedural fields in which the extent and complexity of interactions with patients is less. Doctors are often much less connected to the patients and may never even talk to or see them again after the procedure is completed. You then go on to wonder whether, quote, from their perspective, all the better that doctors in such fields make so much more money than the ones who build relationships with patients. I don't know if there's much to say. It sort of speaks for itself, but I'm wondering what your thoughts were at the time and how you might generalize from that type of student reaction.
First of all, people who aren't equipped to deal with complex emotions probably shouldn't be in medicine. If people are going to trust their doctors, they have to trust doctors to embrace all of their symptoms, all of their experience of the illness. Patients are like inanimate objects that you can just file and act upon. They're people. They need to be connected to, related to, cared about, listened to, hugged, cried with. They're human beings.
Now, you were in charge of a lot of physicians for many, many years, and the bills had to be paid. And I'm curious about how you managed that, given the values you bring to medicine and the large number of physicians who are earning lots of money and the whole issue of RVUs and so forth. And I'm curious, when you put your business hat on, how you managed that challenge.
Well, I'm not a great businessman.
Well, they didn't fire you, and you did it for decades, so you must have been all right.
Well, it's interesting. The Department of Medicine and the health system felt that the deploying of clinicians was too important to be left to an academic like me. And so they made a lot of the decisions. Now, for general internists, it certainly wasn't a matter of us doing unnecessary things to people. I think I always tried to support people having the opportunity to be a little less efficient, especially if they were going to be more compassionate. If someone had put me in charge of a division of cardiology, I'm not sure. I probably wouldn't have lasted very long.
Did you find yourself in situations where you were uncomfortable or angry about the business side? And I'm thinking of scenarios where a physician you recognize as caring and is maybe slower and spends more time with patients because of that, and is yet being hammered to pick up the pace. Did you find yourself in situations like that where you felt uncomfortable as a leader that business decisions were being made that were undermining the doctor-patient relationship and ultimately quality of care?
I tried to be supportive of people who were like that. That's what I could do. I didn't control the purse strings for the School of Medicine or the Department of Medicine anyway. On the other hand, I did comment not infrequently about the failure of UCLA when I was there to take care of enough Medicaid patients. I did comment on the fact that when they were placing practices around the Los Angeles area, they tended not to put them in areas where poor people live. And I always was willing to express my point of view in that regard. I think it's become more difficult for people to speak up about their health systems and about the bad behavior of their health systems. And I think the relentless pursuit of surplus by all these systems, on the one hand, calls for more challenges. And on the other hand, people fear the consequences of speaking up.
Now, physicians often feel, and I'm thinking, I obviously have the most experience with generalist physicians, often become efficient task completers where they're sitting at a computer and they're just essentially trying to get through the visit. Did you have a colonoscopy? Have you had a mammogram? You need a flu shot. Check, 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 check. And they may feel that they may sense that the patient has all kinds of serious issues going on at home that's disrupting their ability to manage their care, that they're in some ways suffering. But I don't have time for that. I got another patient. I got to get through this checklist. This may be the experience for many physicians, and it may even contribute to a sense of burnout. And I'm curious what advice or thoughts you have for that doctor.
Well, there's no question that a lot of people are burdened by the electronic medical record, by the lack of infrastructure support for generalists. I mean, medical students see when they are on the high-paid specialty rotations, there's scribes, there's infrastructure, and often the doctors seem happier, and why not be happier? It's easier. So those are genuine challenges. I think my advice to doctors who are caring and who want to do what's right for their patient is identify some who really need more from you and figure out a way to try to provide that. I mean, some of the stories I tell in the book relate to difficult challenges with patients, but ultimately left me very gratified that I'd put in the effort and taken the time to try to give people what they needed and what they would benefit from. And I benefited as well as a physician.
Yeah, and I think also as a person as well. What I'm thinking about is just that we live in a lonely society right now, and a society where people don't feel connected, which has led to so much desperation. And medicine is part of society, and so physicians are often disengaged from their patients. And I don't mean to romanticize the past because it's not to be romanticized, but there was a time when physicians went to people's homes and where continuity was part of practice. I actually, last weekend, I was in Michigan visiting my father-in-law, who's 93. And I was standing at his bedside, and his doctor walked in to see him, and his doctor has been following him for 32 years, which is actually longer than I've known my father-in-law. And by the way, his doctor is not old. I mean, not old by your and my standards. His doctor actually had been a resident when he picked up my father-in-law, and again has followed him now for more than 3 decades. And obviously, I could see the relief on Gene's face when this doctor walked in. And I felt a sense of envy because I've been an academic physician. I haven't followed anyone for 32 years. And just a sense of, wow, how cool is that? And this is not in a major urban area. And I think that that is something that has been obviously, that type of relationship has been devastated by the healthcare plans and so forth, where people are flipped, their doctors are flipped, and physicians come and go and so forth. But I think that's what you're getting at.
Absolutely. And the long-term relationships that I had with patients were so meaningful, or still are so meaningful to me. I moved to New York from Los Angeles 7 or so years ago, and I still hear from some of my patients. One was particularly angry. She had expected me, as she put it, to see her out, and I wasn't quite able to do that. But those long-term relationships are are great, both for the doctor and for the patient.
I think those days are mostly, they're not over, but most physicians are not practicing in that type of context where they follow patients forever. But I do think that even if you're seeing a patient only once, there is the opportunity to engage, to connect. And so I think that for the physician, there is an opportunity to connect in every encounter. Do you share that view?
Almost every encounter. There's some patients who absolutely don't want to connect, of course, you
Yes.
know,
Yes.
and they just come in with their agenda. But yes, and at the other end of the spectrum, there are some very, very needy patients for whom the connection with the doctor may be the only meaningful connection with another person that they have. And that can present challenges in medicine.
So I just want to stop because I think you're saying two really important points. One is that connection requires two people. And so a physician can be open to connection in the first instance, and the patient may not be interested in connection, but the physician can be open to it. But I think you're right. Connection is by definition, it's a connection, right? And then I think on the other side, you're talking about the patient who has an endless need for connection, in which case the physician has to have some sense of how to manage that with love, but also with boundaries. And I think that becomes a huge challenge. And I find that many physicians, particularly young physicians, are so uncomfortable with that possibility that they are sort of holding patients at a distance. And so I'm wondering if you can say a little bit, particularly given your experience with psychoanalysis, about how you approach, how you maintain connection, but also stay sane when caring for patients who who have an endless need for connection.
Well, one has to establish boundaries and limits, and it's possible to set limits. They aren't always observed. We know people who don't listen to judges when they're told that they're not supposed to do certain things.
Yeah, we've heard about that.
Right. But also, we have to empathize with the patient and their circumstances that cause them to have need at this level. You can't always consign them to a social worker or a psychotherapist because many of them aren't going to be willing to accept that. But understand where they're coming from emotionally can be helpful in terms of processing the experience of dealing with them.
I think it's when I speak personally, I think it's a very long journey to be able to do that. I think that it's so easy for physicians to feel frustrated or angry or irritated and to react to their own internal emotions rather than to be able to look at the patient and say, this is somebody who is struggling. This isn't about me. This is a person who's struggling. And I'm not going to abandon them. I'm going to love them, but I'm also going to set some boundaries. But I'm not going to let those boundaries get in the way of the fact that I'm going to keep a real rapport with this person. I'm going to continue to have a relationship. And the ability to do those things simultaneously, to not react to one's frustration and anger and judgment, that's hard.
It's very hard, and it's an ongoing challenge. It's much easier to pass a colonoscope, I think, than to deal with a complicated patient. Maybe the first 20 or 50 times that you pass a colonoscope, you got a steep learning curve. But with patients, it's a learning curve that is always presenting new nuances, new twists and turns at the splenic flexure, as it were.
Yeah. I feel like one of the messages that's coming out of this conversation, and perhaps it might be the most important, it's one of two, I would say, that I think are critical, but it is that without providing physicians with the skill, and skill isn't quite the right word, without allowing them to grow in a way that enables them to have these relationships, they enter medicine unprepared. And what they do as a kind of workaround is they do become these efficient task completers. They keep patients at a certain distance. They're polite, they're professional, and I put that in quotes, but the engagement, the connection isn't there. And they can spend 30, 40 years doing that, but it's a missed opportunity for connection. It's a missed opportunity for joy in medicine. And it may even be a factor that contributes to burnout. And in some ways, that's the fundamental missing in the way in which we select and prepare physicians for their work. And that's one of the take homes that I'm getting from this conversation and from your writing. Is that a fair take?
I think that's fair. The financial rewards piece needs to be addressed.
That's the other part. That was when I said there were two.
Yeah,
That was the two.
yeah. The financial rewards are absurd for doing procedures. As I argue in the book, there's no reason to have any difference in pay across specialties other than some allowance for additional time in training in some but not all procedural fields that could be amortized over a career and perhaps lead to them earning 10% or 20% more because they spent an extra year or two in training. But other than that, there should be no more reward for an hour spent doing a procedure than an hour spent relating to patients. And if we could get that kind of a thing out of the way, then try to figure out how to address the rest. And the sort of emotional piece, the connecting to patients piece, can be addressed in a few ways, one of which is selecting students who have the capacity to relate meaningfully to patients. Secondly, devote a very large part of the time in medical school to helping students come to terms with this in terms of working on communication skills, learning how to listen to people, finding routes to becoming more compassionate and empathic, certainly altruism and dealing with populations who are in greatest need, and not feeling like you have to terminate interviews so that you can see more patients in the day. All of this can be addressed in medical education. It's barely touched upon. Medical schools don't consider that to be a metric on which they're being judged. Schools proudly talk about the residency programs that their trainees go into. They're often very happy that students get into the most competitive programs, which of course are the highest paying ones. So I think medical schools are failing society, and they're failing their students, given the current curricula, the current admissions processes, and the current priorities. And of course, the students see the ways in which people practice, in the professors practice in medical schools, and a lot of it is not a pretty picture. And they'll emulate the people they see. And again, trying to think about that and trying to reshape that has not been a priority, but it should be.
It's amusing. There's a point where you comment that tendency of doctors to be tempted by wealth is not new, and you quote Plato's Republic, in which Socrates asks, "quote Is the physician a healer of the sick or a maker of money?" I loved it because it's a reminder that this we now live in a much more pernicious environment where healthcare has become a massive industry. People call it a system, but it's an industry. And physicians there's so many ways in which physicians can be corrupted through that process, and medical schools as well. And yet the tendency of physicians, unfortunately, is not a new one to be drawn into, in this case, as Socrates put it, to making money. And so I think that if we go back to the white coat ceremony, which sort of focuses on the nobility of the profession and so forth, and sets a certain tone, I think one of the things that you may be calling for here is a more honest conversation during medical training about not just the nobility of the profession, but the many threats to that nobility, and the many ways in which that undermines the character of the physician and the joy in which they get from their work. And again, that's something that could be part of medical education, in addition to physicians grow in ways that allow them to connect. So there seem to be these two strands.
I agree.
So I want to close by mentioning that I'm reading another book that I love, and I just want to share it with listeners. Some of you may be familiar with Between Two Kingdoms by a woman named Suleika Jawad. And she describes a journey with cancer. She was diagnosed at the age of 21 with acute myeloid leukemia. And she had a very, very difficult course. But her book is gorgeous. But it also describes her encounters in a way that is deeply honest and raw. It gives you a window into the patient experience that is extraordinary in my mind. And you see this sort of disconnect between the kind of lofty language of, say, a white coat ceremony and the reality, in this case, of a young woman who's, and I don't mean to be graphic here, but who's throwing up as she puts it, bloody esophageal mucosal tissue. And no one had told her that that would happen as she went into her bone marrow transplant. No one told her that she would likely lose her fertility if she didn't freeze her eggs before she started the process. At the same time, there are also wonderful physicians. She describes Dr. James Holland, who was her oncologist, who would come in to her room and sit. He would bring in a brown bag lunch and sit with her during his lunch break and just chat with her as a person. And she talked about what an extraordinary effect that had on her in terms of giving her a sense of humanity and keeping her going and just being so touched that her doctor would come and talk with her. And so I think that is that story in many ways, I think, highlights the importance of some of the themes that Martin has been talking about today and in his book. So Martin, I want to thank you for this conversation.
Well, I very much enjoyed the conversation, and I hope people will read my book. The Present Illness was published by Johns Hopkins Press, and they tell me they're coming out with an audiobook soon for people who would rather listen than read. But I'd love to stimulate more discussion about how we can move away from the stasis in the system now to something more like what people need and deserve. Thank you so much for inviting me.
Thanks, Martin. We hope you've enjoyed this latest episode of On Becoming a Healer. If you have and you haven't already subscribed, please consider doing so now. Also, please rate us on the Apple Podcast app, as it will help others find us. And if you have a few moments, leave a review. In addition, if you'd like to make a comment about this episode, we'd love to hear from you. There are a couple ways to do that. If you're using the Apple Podcast app, then just open the episode website link and enter your comment there. Or you can directly go to the website contextualizingcare.org, select the podcast tab, and then scroll down and click on the episode. There you'll find the same comment box. Finally, you can always reach us at onbecomingahealer@gmail.com.